Dear Chairman, dear colleagues, good morning, and thanks one more time to Dr. Cosmidis for the opportunity to be here today and talk today about the ETMR, the embryonal tumor with multilayered rosette. This is a very rare tumor. It accounts for only 1% of the pediatric brain tumors, and it belongs to the family of the embryonal tumors of the central nervous system that were previously classified under the umbrella of the primitive neuroectodermal tumors of the CNS. Not only is a very rare tumor, but it's also a newly defined histological category. It was first described by Eberhardt in 2000 as a new histological category of brain tumors called embryonal tumors with abundant neuropil and true rosette, with the acronyms of AT-NTR. Then, in the last decades, molecular studies identified rare histological entities diagnosed as supratentorial PNET, including ET-NTR, ependymоblastoma, and medulloepithelioma, entities that were sharing recurrent amplification or gene fusions of the microRNA cluster on chromosome 19, called C19MC. So the finding of a common genetic aberration in this tumor suggested that these tumors may represent different manifestations of a single biologic entity. For this reason, the WHO classification of brain tumors that was revised in 2016 introduced the C19MC altered ETMR as a unifying diagnosis of those tumors, of those embryonal tumors characterized by the amplification of the oncogenic microRNA locus C19. Pathology-wise, the pathognomonic histological feature is represented by the presence of a multi-layered and mitotically active rosette consisting of pseudostratified neuroepithelium with a central lumen. The characteristic C19 alteration, which is present in 90% of the ETMRs, can be detected by FISH analysis. Also, all the ETMRs stain positively for the immunohistochemical marker Lin28A, generally with a diffuse pattern of positivity. But Lin28 doesn't have a 100% specificity, since it can also be expressed in other malignant pediatric brain tumors, such as the ATRT. Around 90% of the ATMRs harbor alteration in the C19 locus and are classified as C19MC ATMRs. The remaining 10% of the Lin28 positive tumors histologically resembling ATMRs are C19 negative and are classified as ATMR non-otherwise specified. And in this subset of tumors, we could have frequently biallelic DICER1 mutation. So let's just keep in mind that there could be a possible germline DICER1 mutation in these patients. Around 90% of ATMRs occur in the first 3 years of age, and median age of diagnosis is 2.5 years. 2/3 of the tumors are supratentorially located, but we can also have ATMRs in the cerebellum, in the brainstem, and more rarely in the spinal cord. Most of the children have localized disease at diagnosis, but up to 27% of the tumors can present with metastatic disease. And here it is interesting to note that there is a 15% of these metastatic tumors which can have metastases outside of the central nervous system. Regarding the radiological aspects, ETMRs present the MRI as large tumors with frequent calcifications, little to no edema, absent or weak contrast enhancement. They can have an intratumoral large vessel. They present with restricted diffusion, and at the spectroscopy they have a high choline-creatine ratio. Now, clinically, ETMRs follow a very aggressive course, with the majority of the children experiencing relapse or progression during treatment or immediately after the completion of the treatment, with an overall survival at 2 years of only 29%. At present time, there is no current standard of treatment for these tumors. So I will provide you here with a quick overview of the results of the main protocols that have been adopted in Europe and in North America. Here in these slides, we have the results of the German protocol on 34 patients with ETMR who were treated with surgery, followed by 2 cycles of induction chemotherapy with carboplatin and etoposide plus intrathecal methotrexate, followed by 2 cycles of high-dose chemotherapy and intrathecal methotrexate. Now, at the end of high-dose chemotherapy, children with complete response did not receive any further treatment, whereas children who had less than complete response received radiotherapy, either focal or focal plus craniospinal irradiation. Despite the aggressive treatment, the overall survival at 5 years was only 28%. So the authors of the study also were interested in comparing the children from this cohort who received the high-dose chemotherapy with an historical cohort of children that had been treated only with conventional chemotherapy. And they could evidence a benefit in terms of overall survival in children who received high-dose chemotherapy. In this population, there were 5 children who finished the high-dose chemotherapy with a complete response and were not treated with upfront radiotherapy. 2 out of 5 relapsed and died, whereas 3 children remained long-term radiotherapy free. Relapses were mainly local. 60% were local, 18% were distant, 22% were combined local plus distant. So the authors point out in the discussion that the risk and benefits of irradiation need to be carefully considered. In the absence of metastasis or early disease progression, the use of upfront local irradiation may be a reasonable treatment choice for young patients who would not tolerate craniospinal irradiation. Similar results were obtained with the French protocol, which was based on surgery, 2 induction chemotherapy, again carbo-etoposide, followed by sequential high-dose chemotherapy and reduced dose radiotherapy. Here again, the overall survival was quite poor, with only 30% at 3 years. The identified prognostic factors were the gross total resection, the high-dose chemotherapy, and the radiotherapy. On the other side of the ocean, the cooperative group protocols adopted in the United States are based on a first phase with an induction chemotherapy with 3 to 5 cycles, based on a platinum etoposide regimen with or without the addition of cyclophosphamide, vincristine, and methotrexate, followed by high-dose chemotherapy for 1 to 3 cycles, with or without radiotherapy. The results have not been published yet. So we have seen that most of the protocols, they include aggressive approach with high-dose chemotherapy. But just for the completeness of this overview, we have to mention that there are also protocols who believes in the efficacy of conventional chemotherapy, such as the Dana-Farber protocol. At the Dana-Farber institution, children with ETMR are treated according to the ATRT protocol, which is based on prolonged chemotherapy for up to 51 weeks. And this chemotherapy includes doxorubicin and dactinomycin, which are two drugs that are not commonly used in the pediatric brain tumors because these are big molecules and they don't really penetrate very well the blood-brain barrier. In this protocol, focal radiotherapy is also delivered, and together with the chemotherapy, also triple intrathecal chemotherapy. But the protocol does not include any high-dose chemotherapy cycle. 5 patients have been reported treated with this protocol, all with localized disease. 4 patients had a progression-free survival of more than 18 months, but of course, very few patients to draw any conclusion. So the use of doxorubicin and dactinomycin has as a rationale the results of a preclinical drug screening study published by the German group. In this study, an ETMR cell line has been used to screen 35 compounds, and the results show that the actinomycin D, topotecan, and doxorubicin kill ETMR cells at low concentrations. The results were further validated in vivo on a patient-derived xenograft model, from where the best performing in vivo compounds seem to be topotecan, volasertib, and actinomycin D, followed by doxorubicin. So, in this moment, the best treatment approach for ETMR is unknown. But if we look at the largest study regarding children with ETMR that has been recently published by the Canadian group led by Dr. Wang, we see that in this study, in which clinical data from 159 patients were collected, patients that were from North America and Europe. So, knowing that this is the largest study that has been published so far, looking at the results, we can see that from the multivariable analysis, the main prognostic factors associated with a favorable outcome are the gross total resection, the administration of high-dose chemotherapy, and the delivery of radiotherapy. And these results suggest that probably ETMR may benefit of a multimodal therapeutic approach. More in details, all children that have been treated in the study with conventional chemotherapy regimens without radiotherapy, even including those with gross total resection, died relatively rapid with 0% overall survival. On the contrary, all of the patients with a prolonged overall survival had all received a high-dose chemotherapy treatment. Radiotherapy seems to correlate with improved overall survival in patients prescribed high-dose chemotherapy, irrespective of extent of surgery. And children who received gross total resection plus high-dose chemotherapy and radiotherapy could achieve an overall survival at 2 years of 66%. Also, most of the children who survived for more than 2 years, they had received focal radiotherapy or high-dose chemotherapy without radiotherapy, suggesting that craniospinal irradiation is not necessarily warranted for the majority of the ETMRs. And indeed, 77% of the relapses were local relapses, either local or combined local plus metastatic. In this moment, there is a lack of novel therapeutical option, but given that epigenetic and DNA repair processes seem to be involved in the pathogenesis of ETMR, there are ongoing experimental studies that are investigating the role of mTOR inhibitors, topoisomerase, aurora kinases, histone deacetylases, bromodomain inhibitors, polyamine inhibitors, and DNA methylation agents. The results are awaited. So now, close to the conclusion, just a quick case report of a child that was recently treated at ΜΗΤΕΡΑ. It's a child that was 18 months old at diagnosis. He presented with a medical history of 1 month progressive gait disturbance. MRI of the brain showed the presence of a large brainstem tumor with no contrast enhancement and the presence of a central vessel. He underwent a surgical partial resection, and the histology was in favor of an embryonal tumor. So a pathology review was demanded at the SickKids Hospital in Toronto, and the final diagnosis was ETMR C19MC altered. The staging with MRI of the spine and CSF cytology didn't show any metastatic dissemination. So discussing the case with the neurosurgeon, and given the fact that a gross total resection was very difficult to obtain, our we conceived a treatment strategy based on an initial 2 induction courses of chemotherapy with the hope, with the aim of obtaining a tumor shrinkage that could have facilitated the neurosurgeon job in order to obtain a second look surgery, which would have been followed by high-dose chemotherapy and focal radiotherapy. Unfortunately, after 1 course of induction chemotherapy, the magnetic resonance showed a local progression of the disease. So the neurosurgeon went for a near total resection, and we decided to anticipate the radiotherapy given the chemo resistance that was showed by this particular tumor. At the end of the radiotherapy, the MRI once again showed a progressive disease, this time local and metastatic. So our second-line chemotherapy was temozolomide plus irinotecan plus intraomaia topotecan. Once again, we had a progression disease, but interestingly, this was a dissociated response, because from one side we had the progression of the nodular metastasis, but on the other side we had the decrease of the supratentorial diffuse leptomeningeal enhancement, possibly due to the use of the intrathecal topotecan. So we continued the treatment in a palliative setting with the intraomaia topotecan for a total of 8 doses. And the child eventually died of disease progression at 9 months from diagnosis. this extremely aggressive and chemoresistant behavior is that we observed in this child is compatible with what have been reported in the literature, again from the Canadian group, who published about 17 children with ETMR of the brainstem. Only one of these 17 children survived, and this child was the only one who underwent a gross total resection, and like the other one, high-dose chemotherapy and radiotherapy. So in conclusion, ETMR should be promptly identified by routine C19 FISH and Lin-28 immunohistochemistry in all infants with embryonal brain tumors. Patients with ETMRs should undergo maximum safe tumor surgery, followed by multi-agent high-dose chemotherapy. And because most of the patients with ETMR are very young children with frequently large hemispheric tumors, the use of focal radiotherapy and its timing should be carefully considered in relation to patient-specific risk features and response to induction chemotherapy, high-dose chemotherapy, and repeated surgery. Also, the physician has to consider early focal radiotherapy with or without repeated surgery for patients with subtotal resection or gross total resection with local relapse progression, and for all patients with residual tumor at the end of high-dose chemotherapy. Also, due to the dismal prognosis despite most aggressive therapies, new treatment approaches, including genomic and preclinical data defining therapeutical susceptibilities, are needed. Thank you very much for your attention.
Πολύ ευχαριστούμε, Βίτα. Ήταν πραγματικά πάρα πολύ ωραία η εισήγηση και δείχνει πραγματικά το μεγάλο πρόβλημα που έχουμε με αυτούς τους όγκους. Ευτυχώς είναι, όπως ανέφερες, πάρα πολύ σπάνιοι, αλλά είναι ιδιαίτερα επιθετικοί και δεν απαντάνε καλά στη θεραπεία. Νομίζω ότι έχουμε το χρόνο να γίνει κάποια συζήτηση. Δεν βλέπω κάποιο στο chat, οπότε αν μου επιτραπεί εγώ να κάνω κανένα δύο ερωτήσεις. Νομίζεις ότι η καμπύλη κάποια στιγμή κάνει πλατό ή το relapse μπορεί να συμβεί οποιαδήποτε στιγμή εν ευθέτω χρόνο?
Βασικά είναι τόσο επιτετικούς αυτοί οι όγκοι που οι περισσότερες υποτροπές γίνονται στα πρώτα 2 χρόνια. Οπότε βασικά μετά από τα 2-3 χρόνια, δηλαδή αν έπρεπε να γίνει υποτροπή, θα είχε γίνει. Ναι.
Ωραία. Και θα ήθελα να ρωτήσω την κυρία Στεφανάκη που είναι μαζί μας στο Προεδρείο. Είναι πραγματικά τόσο χαρακτηριστική εικόνα η παθογνωατομική ή νομίζουμε ότι είναι απαραίτητο το προφίλ μεθυλίωσης που γίνεται τελευταία σε πολλούς από αυτούς τους όγκους?
Καταρχάς, θα ήθελα και εγώ να ευχαριστήσω για την πρόσκληση, την κυρία Κοσμίδου, να συμμετάσχω σε αυτή την πάρα πολύ ενδιαφέρουσα επιστημονική συνάντηση και κυρίως να συγχαρώ την κυρία Ρίδολα για μια εξαιρετική παρουσίαση σε έναν όγκο τον οποίο ευτυχώς δεν το βλέπουμε πολύ συχνά. Μπαίνει όμως αυτό το ευρύ φάσμα των εμβρυονικών νεοπλασμάτων, το οποίο ο παθολογανατόμος πρέπει να έχει υπόψη του και μέσα στο πάνελ των αναστοχημικών δικτών που χρησιμοποιεί, θα πρέπει οπωσδήποτε να χρησιμοποιήσει και ένα Lin-28α και δεύτερον βέβαια να χρησιμοποιήσει και τα γνωστά μας αντισώματα για να αποκλείσει τους άτυπους ραβδορείς θεραπευτικούς όγκους που συχνά μπαίνουν στη διαφορική διάγνωση. Μορφολογικά είναι λίγο δύσκολο να μπορέσει κάποιος να βάλει μια επίσημη διάγνωση ETMR. Μπορεί να τον υποπτευθεί. Και μπορεί να τον υποπτευθεί πότε? Όταν έχει ένα εμβρυονικό νεόπλασμα που έχει πολλές επενδυμαπλαστικές ροζέττες, δηλαδή τις πολύστιβες ροζέττες με την καινούργια ταξινόμηση, ή όταν έχει την κλασική εικόνα του παλιού ETMR, δηλαδή εκείνου που έχει πάρα πολύ νευρονιδιακό υλικό και αληθείς ροζέττες. Αλλά πιστεύω ότι σε όλους αυτούς τους όγκους θα πρέπει μέσα στο αναστοχημικό πάνελ να περιλαμβάνεται το Lin-28α, το οποίο, όπως είπε και η Βίτα, δεν είναι πανάκια. Διότι μπορούμε να το δούμε και σε άλλους όγκους, όπως είναι η άτυπη ραβδοειδή, ή μπορούμε να το δούμε και σε high-grade γλιώματα. Οπότε Για να είμαστε εντελώς σίγουροι, θα πρέπει οπωσδήποτε, αν έχουμε μεγάλη πόνοια μορφολογική και ανοστιχημική, να ζητήσουμε οπωσδήποτε ένα φρις για να αποδείξουμε το C19MC amplification σε πρώτη φάση. Τώρα, το αν η μεθυλίωση, δηλαδή να χρησιμοποιήσουμε την προφίλ μεθυλίωση θα μας βοηθήσει, ασφαλώς, είναι η τελευταία μέθοδο. Δηλαδή, είναι εκείνο το οποίο θα βάλει και την ταμπέλα του όγκου. Αλλά νομίζω ότι ο συνδυασμός της μορφολογίας και ενός φρις που θα δείξει την επάυξη του C19MC μπορεί να οδηγήσει στη σωστή διάγνωση σε ένα αρκετά μεγάλο ποσοστό αυτών των σπανίων όγκων.
Πολύ ευχαριστώ. Δεν ξέρω αν η Βίτα θέλει να προσθέσει κάτι.
Εντάξει.
Okay. Και να κλείσουμε μια τελευταία ερώτηση. Ήταν πολύ ενδιαφέρον το άρθρο που παρουσίασες για την ακτινοβολία. Το ερώτημα βέβαια που τίθεται πάντα σε αυτούς τους ασθενείς, στους όγκους οι οποίοι είναι πολύ επιθετικοί, οι ασθενείς που τελικά καταφέρνουν, ή μάλλον στην πορεία, μέχρι να φτάσει στην ακτινοβολία, πολλοί από τους ασθενείς έχουν ήδη καταλήξει, έχουν υποτροπιάσει, οπότε φεύγουν από το αρχικό cohort. Οπότε μήπως τελικά αυτοί που καταλήγουν, καταφέρνουν να φτάσουν στην ακτινοβολία είναι επειδή έχουν λιγότερο επιθετικό όγκο. Δεν ξέρω αν...
Συμφωνώ, έχω κάνει τις ίδιες σκέψεις. Βασικά υπάρχει ένα selection bias στα αποτελέσματα, επειδή όντως τα περισσότερα πρωτόκολλα δίνουν την ακτινοβολία στο τέλος και προσπαθούν και να κερδίσουν χρόνο του postpone τη ραδιοθεραπεία λόγω ηλικία. Οπότε, αν φτάσουν στην ακτινοθεραπεία, σημαίνει ότι για κάποιο λόγο αυτό τον όγκο είναι λιγότερο επιθετικό, επειδή οι άλλοι, όπως αυτό που παρουσιάσαμε εμείς σαν case report, κάνουν υποτροπή και πολύ νωρίς και έχουν μια πολύ σημαντική κοιμειοανθετικότητα. Και γι' αυτό τον λόγο το άλλο είναι να μην πάρουν, ένα άλλο θέμα είναι να μην φτάσουμε στην high dose chemotherapy μετά από πολλούς κύκλους, να έρθει αρκετά νωρίς η high dose chemotherapy, αλλιώς θα κάνουν υποτροπή με το induction chemotherapy.